Hello, it's John Canalopoulos from our center here in Athens, Greece, the Laser Visual Ambulatory Surgery Center, Clinical Professor of Ophthalmology at NYU Medical School, New York City, New York. Our favorite subjects, as you guessed, keratoconus. This is the right eye of a 58-year-old lady. The secret with this eye that I will reveal now is that it's pseudophakic. She had, this eye is not pseudophakic. This eye is pseudophakic, the left eye. And we can see that keratoconus here, steepest K is 57.3. This eye is 53.5. So a little bit milder keratoconus in the right eye, the more advanced left eye. And remember, 58 years old, female. This is the pseudophakic eye. And we see a little bit of haze here of the keratoconus. Probably from older use of contact lens. This is the intraocular lens. We're seeing some yak capsulotomy spots on the lens. She also complains of continuous tearing of her right eye that she wears a contact lens. And she exhibited to us how she wipes her eyes with a clean tissue, and she clearly fishes mucus. As she pushes on her eyelids at this area, the eyelids open, and she wipes this area, which gives extreme comfort and pleasure to the patients to wipe the mucus, but that reignites and refuels the mechanism of mucus fishing syndrome. This is the fundus, which is okay, just an RPE hypertrophy there. And these are the, as we mentioned before, the cornea pentacams of the left eye. Now, the area I wanted to focus is the epithelial maps. This is the left eye that does not wear a contact lens. She had cataract surgery. Her correction here is -1.5, -3 of astigmatism. So the IOL calculation classically, and I explained this to her, sometimes is off. It's very difficult to calculate intraocular lens in keratoconic patients, although modern formulas are better, and this is a very central cone. So with some of the modern keratoconic corneas, formulas rather, the calculation would have been better. Nevertheless, we still have thickness here. She's 413 on the OCT. We could theoretically correct some of the refractive error, but what's worrisome here is that the epithelium, and again, this is not the eye that's wearing a contact lens. The other eye is wearing a piggyback lens. The fact that the epithelium, even at 58, is blue tells us that she is rubbing this eye. She's not rubbing it during the day. She cannot recall doing it at night. We asked her to tape the way she sleeps at night because we feel she'll find out that she's actually rubbing the left eye, and that's an area of concern because even if she's 58, this means the keratoconus here is active and we need to stop that habit. An OCT of the macula. I had somewhere here pictures of, we're gonna go to the IOL master, where we can clearly see the same numbers. The actual length is 26 and almost 26. So even if she was not keratoconic, this lady would have had myopia. So some of her myopia is axial and not from the keratoconus. And if I go back to look, the last piece of the puzzle here is I wanted to see the epithelial maps of the right eye. And the right eye is phakic, is developing a cataract. She's wearing piggyback contact lens, and look at the epithelium here. Is this active keratoconus? Is this warpage from the soft lens on top of which the RGP lens is worn? Cornea thickness here is a little bit thicker, 419, and the cone is a little bit more eccentric. Probably a little bit of both as far as whether there's eye rubbing going on in the left eye when she takes her lenses off, or this is from contact lens wear. But as we discussed before, it is our clinical judgment that this finding here, this is the left eye again, trying to find, this is the left eye again, the epithelial maps, is a clear sign that she's rubbing her eyes, likely during the sleep. So, what we propose to this lady, number one, to stop wiping her right eye. Always patients are skeptical, but the eye is tearing. What am I gonna do? We have to convince him somehow to not wipe it for a week and see if the mucus fishing syndrome symptoms will resolve. Number two, get a soft contact lens with her refraction here, which again is -1.5, -3 diopters of astigmatism. Try it on. We'll try and do an over refraction over that. To note here that with spectacular refraction, this eye reaches a little better than 20/30. The other eye with the piggyback contact lens is almost 20/20. So if with the soft contact lens, her vision is good, she can continue wearing a soft contact lens. She can wear a piggyback contact lens. She can wear a sclera contact lens. If none of the three is a good option for her, she can undergo a surface ablation. Since we feel keratoconus is active, we will couple that with a prophylactic CXL treatment, maybe 30 milliwatts per centimeter square for 3 minutes, in order to enhance a little bit the cornea stability, anterior lamella of the cornea. We still have a little bit of room to do that treatment. So again, we did discuss with her that when time comes to do her surgery in her right eye, and her right eye lens thickness is over 5 millimeters, so we know this cataract is cooking and will soon be in the front page for this patient because this is her better seeing eye. We can see also the fantastic IOL-Master 700 images of the pseudophakia here, and also the comparison of how thick a synthetic lens is, thickness of 400 microns versus the 5 millimeters, a little bit over 5 millimeters for the Cataractus lens. Again, I was saying, we mentioned to her that the IOL calculations will be a challenge on the right eye as well, and if after cataract surgery, and if she desires to do so with a toric lens, there's still a residual refractive error, again, the same algorithm: soft contact lens, RGP lens, piggyback RGP lens, or sclera lens, or a surface ablation. Again, some of the challenges of a case which I think it was managed very well. The cataract procedure looks impeccable, was done by a colleague. IOL calculation is always an issue with keratoconus, and it's important for us as clinicians to transfer this fact to patients and explain to them that this is not a matter of surgical skill for the procedure, but more of experience with IOL calculation formulas in keratoconus that are quite challenging. Again, John Kanellopoulos from Athens, Greece. Very, very interesting subject here. Hope you find it interesting. Signing out. Thanks very much for your attention.